Good evening, ladies and gentlemen. Welcome to yet another academic feast from ISA Thrissur City branch. Monkeypox, the latest of the epidemics from which have been attacking the universe and which has been causing concern both to the common man as well as the medical personnel all over the world, is the latest among the epidemics which has arrived. And so I think to know about this, we have got an excellent person, an excellent resource person, Dr. Deepu, to speak on this and to clear doubts if so any, if you have. So once again, with these words, I welcome each and every one of you to this meeting. Over to you, Soumya.
Thank you, Doctor. So I'm taking this opportunity on behalf of MedPiper Technologies and ISA to welcome our speaker for the day, Dr. Deepu TS, to talk about monkeypox and what we know so far. So Deepu TS, Associate Professor, General Medicine, Division of Infectious Disease, Amrita Institute of Medical Science, Kochi, started the career as an intern, worked and published both national and international articles accordingly from understanding dengue and COVID-19. Dr. Deepu have done large research and publications in collabs with ICMR, Serum Institute, Amrita University, to name a few. He started the career as an intern, worked and published both communicable and non-communicable disease, later got interested in the infectious disease and published and reviewed several national and international journals. Thank you, Doctor, for joining us today. Over to you.
Thank you, Soumya. Thank you. Thank you, Soumya. Thank you, Dr. Nivin, sir, for that excellent introduction. I will start screen sharing.
Sure, Doctor. Yes, Doctor, PPT is visible, no problem. You can start.
My screen is visible, right?
Yes, yes, Doctor.
Okay, 1 second. So good evening, every participants. Welcome to this seminar on monkeypox. So I was just asking Soumya what are the type of audience who are here to listen about the monkeypox, and then I understand that it's more like general practitioners are there, then BSc, MSc, as well as interns, house surgeons are also there. So I will modify my speech accordingly. And in case if someone wants to know something in detail at the end of the session, please feel free to ask. Okay. Oh, I think. Okay. So when we hear the term monkeypox, usually when we hear any term, as a matter of fact, we always try to relate to other similar terms which we have heard. So, though the monkeypox is, before this month, many of us would not have heard the term monkeypox, but other pox viruses term we always know, like smallpox and chickenpox. So let's see whether monkeypox has any relationship with smallpox or chickenpox. When we look at the taxonomy and classification of the monkeypox, it is coming under the family of poxviridae, orthopox virus. And in that same family, not only monkeypox, but other viruses such as variola, vaccinia, camelpox. So other pox viruses are also there in the family. So the variola virus is our classical smallpox virus. So the monkeypox is more related to taxonomically or family wise, it is more related to the smallpox virus family than the chickenpox virus family. Chickenpox virus family related completely to a different family called herpes virus family. So that's about the basic virology. Now coming to the history, how the term monkeypox happened. So monkeypox was first discovered in 1958 when two outbreaks of pox-like disease occurred in Congo among the monkeys kept for research. So since it was first identified in monkeys, the term monkeypox. As far as human monkeypox, as far as monkeypox is concerned, identified in humans, that happened in the year 1970 in the Democratic Republic of Congo. That was in a 9-month-old boy. Since 1970, human cases of monkeypox have been reported in 11 African countries. Okay, so this is the picture of Africa. You can see mainly the tropical portion of the Africa consists of Congo, Sudan, Nigeria. So that is in the central part of the Africa as well as the western part of the Africa. So that is the African region, which is classically had so many cases of monkeypox. So the tropical climate and the central and western Africa, that is the region where we have seen a lot of monkeypox cases. Other than the African region, we in 2003, the outside the Africa, in United States, there were cases of monkeypox, and following which there was a small clustering of outbreak, and there were up to 70 cases. But the index cases and majority of the cases had epidemiological relationship with the African continent. And ever since, there were multiple reports of monkeypox in countries like United Kingdom, Singapore, and United States of America as well. But again, as I told, the epidemiological link was always there. But this is the first time in May 22 onwards, there are multiple cases of monkeypox identified across the globe without any link to the African continent. So that is why we are a bit scared about the monkeypox during the current epidemic. This is the chart of United States of America, and in which you can see the number of cases of monkeypox is maximum in the New York City. And why is it so? Because in the New York City, there's LGBTQ community. They have celebrated the Pride Month, and the LGBT community and homosexual men are kind of the law is kind of liberal, and because of which there is a preponderance of infection in the New York City. And as far as 2022 monkeypox outbreak is concerned, you can see the majority of the monkeypox are still in the United States of America as well as in the European continent, where there are a lot of rape parties as well as other activities. Whereas the other, of course, the other parts of the continent as well as other part of the world is slowly reaching that level, but still at this point of time, it's mainly concentrated in the urbanized, westernized world. And as of today, we have more than 23,620 confirmed cases of monkeypox with 80 countries involved. And out of which 73 countries have reported monkeypox for the first time. And what about the monkeypox tally? Is there any trend of slowing down, or is it still going up? So from this graph, you can very well understand that from May 2022 onwards, where the world came to know about the outbreak of monkeypox, from that day onwards, in every month, the number of new cases is slowly increasing. But still you can see the number of new cases per month is not very high as compared to that what happened in cases of COVID, but still it is going up. Why are we so much worried about monkeypox? Because if it was some previous era or previous decade, we would not have definitely worried this much about monkeypox. But since we know what COVID has done to our world, we are very much worried whether it will restrict our freedom, whether it will restrict our social and economic impact it had in our society, whether there is going to be another epidemic. That is what really worrying us. But the WHO was this time, unlike the time of COVID, WHO has declared it as global public health emergency of international concern on July 23rd. And this is the first outbreak which marked the disease spread outside Central and West Africa, other than the sporadic cases which I have already told, which always had epidemiological link to the Africa, which means now an individual does not need to travel back to Africa to get the disease, but it is there in their own community. So that is what scares the World Health Organization. And we are essentially from Kerala. I am essentially from Kerala, and majority of us are from Kerala. So we know we were very prompt in diagnosing and detecting diseases. We have first reported the Nipah, we have first reported the COVID, and in monkeypox also, we are still first. And Kerala has first reported the first case of monkeypox in India. And as of today, third, I don't know, whether the statistics has changed now, but by this afternoon, this was the statistics. The third monkeypox case detected in Delhi, and total, there are 8 cases in India so far. And this is a Malayalam news stating that the first mortality or first death has been reported due to monkeypox, and that too again in Kerala. This is the monkeypox viral structure. I am not going into the detail. In case if someone would like to know, then maybe towards the end of the session, they can ask questions and maybe I can explain a bit more. But you need to just understand that it is a pox virus and coming under the DNA virus family. Again, how it modulates the cellular dynamics by which it helps the pox virus to thrive in the cellular environment of the host. So that is what this picture depicts, but still I think I will skip this. And what are the modes of transmission of monkeypox? This is something which we are very interested to know. So historically, it was always limited to an area of Africa. Why was it always limited to an area of Africa? That is because it was classically considered as a zoonotic disease. So what is a zoonotic disease? Zoonotic diseases means it is a disease which transmits from animals to humans. So, and that too, because even though the term is monkeypox, it was basically the reservoir of the virus was squirrels and rodents, rats. So from them, accidentally, sometimes monkeys or humans will get infected. And that was told to be the classical way of transmission of the monkeypox. And how will the disease spread from the animals to humans? Via blood or body fluid contact or bite or scratch of animals during the hunting, cooking, and consumption of infected animals, or even if the rodent or squirrel or animal who has monkeypox, if there is a cutaneous or mucosal lesion, if somebody is touching that lesion, they also can develop the monkeypox. So this is how the classical description of monkeypox, and this is how monkeypox has thrived up till this decade. But suddenly something has changed, and now we are seeing human-to-human transmission, which was very, very rare before. And now we are seeing human-to-human transmission, and there is no need for a reservoir. The humans himself are acting as the reservoir, and they are spreading the disease from one person to the other. How are they spreading the disease? As we know, in the recent article, in the last week, in the recent article published in NEJM, more than 90% of the cases were men who have sex with men or the homosexual men. So basically, the sexual transmission is the predominant route of transmission as of today. But is it the only route of transmission? No, it is not the only route of transmission, because right now we are seeing more cases of monkeypox in children. Last week, US CDC has reported 2 children developing monkeypox from the same family. So why are they developing? Because of close contact. If somebody is hugging or somebody is kissing or somebody, even that is all those hugging, kissing, all those are direct contact. But even with indirect contact, for example, a person with monkeypox slept in a bed and he left, and a person who doesn't know about the fact the linen might contain the monkeypox virus can sleep in that same bed, and definitely there is, even though the risk is small, definitely there is an exposure. So this is like indirect exposure. So direct exposure is there, indirect exposure is there, and then definitely respiratory droplets. So if you are speaking face to face with a patient without mask for a prolonged period, not for a small period, but for a prolonged period, then there is a possibility of you getting monkeypox via the respiratory droplets. Not like chikungunya, not like COVID. COVID, it is mainly a respiratory transmission, and it is not a droplet transmission. It is airborne transmission. That means even with the minutest salivary particle, an infection can spread from one person to the other. But this is a droplet transmission. That is not via the minutest particle, but via large salivary droplets only infection can transmit. So this is the modes of transmission. This is very important because if you want to contain the infection, you should have an idea how it spreads. Okay. So regarding the vertical transmission, many of you might have the doubt whether there can be transmission from pregnant mothers to their fetus. So the answer is yes. The details maybe we can discuss later. And what is the pathogenesis of monkeypox? How is monkeypox is causing this illness? So the explanation I already told, via respiratory droplet, direct or indirect contact, the monkeypox virus enters the human body. And if it is entering via the genitalia, or if it is entering via the oropharynx, then what happens is that it enters the oropharyngeal mucosa, where it multiplies, and the multiplication of the virus results in primary viremia. That means the virus multiplies in that particular area. From there, it spreads to the blood. So that is known as the primary viremia. And when primary viremia happens, this virus will infect other parts of the body, like spleen, lymph node, and there it will multiply again. So in the lymphoid organs, it will multiply again. And when it reaches a particular threshold, the virus will again spill over to the blood, resulting in secondary viremia. And at the time of secondary viremia, all the tertiary organs, including lungs, brain, kidneys, all these things can get involved. The patient may not become symptomatic, but can get involved. But the main predominant organ system which gets involved is the skin. In more than 80% of the individuals, there will be skin involvement, and there will be cutaneous manifestation. So that is how a monkeypox patient is going to present to a doctor with cutaneous manifestation. So what are the cutaneous manifestations? So the cutaneous manifestations, it goes through certain stages. The first stage is ananthem, where you can get an oral lesion or a genital lesion or even an anal lesion. And then there will be cutaneous manifestation. First, there will be reddish lesions, but it will not be raised, known as macules. And in a 1 to 2 day time, the reddish lesions will get raised, and it forms the papule, and then macule, then papule, and this papule will, the inside of the papule is usually solid, and it will get liquefied, and it forms a vesicle kind of structure. So in 1 to 2 days, macule, then 1 to 2 days papule, and in another 1 to 2 days, it forms vesicle. And the vesicle will get a lot of neutrophils, and it will turn yellow, like a pustule. Okay, so small infection, abscess kind of thing, usually we will get now. So similarly, a pustule will form. The pustule will be there for a prolonged period, like a week. And finally, the pustule will drop off, and then there will be a scab formation. So that is how the clinical scenario or the cutaneous manifestation of the monkeypox goes. So the whole thing will take anywhere between 2 to 3 weeks. So 14 days to 20 days the whole thing will unravel in 14 days to 21 days. So the thing is that the monkeypox patient is going to be sick for a bit more prolonged period. So again, the vesicle, the pustule, the umbilicated pustule, the early scab formation, late scab formation, and in the last image you can see the scab is falling off. So that is how a patient is going to present to you. Again, similar picture, just highlighted the picture, that's all, in case if you missed it. So these kind of presentations will be there in more than 80% of the patients. So what about this? This is, as we know, this is the classical chickenpox. So one thing which you all wonder is that how will we, because any given point of time, chickenpox cases will be much more than the monkeypox cases. So you are highly likely to come across a chickenpox case rather than a monkeypox case. So how will you differentiate between chickenpox and monkeypox? So chickenpox is the superficial blisters. So blisters or vesicles are there, and as you see, it is more common in the truncal area. Whereas in case of monkeypox, it is more commonly in the facial as well as the hands as well as in the legs. Even the palms and soles will get affected. So chickenpox is more like in the trunks, and monkeypox is more like in the hands and face. So it's more like centrifugal, whereas chickenpox is more of a centripetal kind of disease. So there is another disease called, how will you differentiate between monkeypox and chickenpox? There will be appearance of the rash. The rash will progress, and the rash duration. Chickenpox, usually it will rarely last for more than 5 days, whereas in monkeypox, it can easily last more than 14 days. And the rash progression, I have told, in case of monkeypox, the rash progress through stages. And at a given point of time, in a given individual, the rash will be in a particular stage. Whereas in chickenpox, as I had shown in the previous image, you can see in a given patient, there will be vesicles, there will be some lesions which are already started scabbing, and there are some new onset vesicles. So the pleomorphicity is a feature of the chickenpox, whereas in monkeypox, uniformity is the feature of monkeypox. And lymphadenopathy. Sometimes if the patient, if the virus is entering via the oropharynx, there will be regional lymphadenopathy. So regional lymphadenopathy is there in monkeypox, but it is not there in chickenpox. So using these features, clinically a doctor can differentiate between monkeypox as well as chickenpox. This is another disease called hand-foot-mouth disease. How to differentiate between hand-foot-mouth disease and monkeypox is also a common discussion among the doctors, but I think that might be a little too much for the current crowd. So I will skip for now. In case if you have doubt, maybe towards the end of the session, we can get back to it. And now about the transmission period. Monkeypox can spread from the time symptoms start until the rash has fully healed and a fresh layer of skin has formed, which means the illness typically last for like definitely more than 2 weeks, 2 to 4 weeks, maybe a little overestimation. But the transmission period is definitely up till 3 weeks. So up till 21 days, a patient can transmit the disease, and hence the isolation period will be 21 days. And regarding the current outbreak, I have already told, most are happening in MSM men. And not only the cutaneous presentation we are commonly seeing, but the other kind of presentations like genital ulcers, perianal ulcers, the inflammation of the anus, proctitis. Even the patient can present to you with prodromal symptoms. But when a patient presents to a dermatologist or a physician with proctitis or genital or perianal ulcer, so that point of time, the history is very important. The patient may or may not have prodromal symptoms. They can even present to a STD clinic. So these kind of presentations we need to understand. So when will you suspect a case of monkeypox? So you need to know that there are atypical features and there are typical features. So atypical features include swollen lymph node, fever, headache, body weakness. And along with that, in order to suspect, there has to be an epidemiological link, or there has to be a link to a patient who is suspected of monkeypox or who had monkeypox. And for a probable case, clinically compatible illness has to be there. And again, the epidemiological link has to be there. For a confirmed case, an individual who is suspected to have monkeypox, their fluids or tissues, if when sent to virology lab, using the PCR technique, if the monkeypox virus gene, DNA, if it's detected, then it is a confirmed case. So these are the various definitions. Again, how to differentiate various clinical scenarios between monkeypox and smallpox and chickenpox. That's what I have tried to portray in this figure, but I think we will discuss towards the end if required. You need to understand that all rashes are not monkeypox. There are certain very common differentials, or certain rare differentials as rare as monkeypox, which we need to consider. One is, of course, another sexually transmitted disease, the secondary syphilis, which can present with palmar rashes. And again, a picture of secondary syphilis where there could be rashes over the body. And cryptococcal infection, which usually happens in HIV individuals. So disseminated cryptococcal infection can also sometimes get mistook for monkeypox. And now this pertinent question, what are the complications of monkeypox? This we need to discuss, because we know that the death rate of monkeypox is kind of very low. Outside Africa, there are only 3 or 4 deaths has been reported, out of which 1 death happened in India, Kerala. So how did monkeypox killed that particular individual? So that we need to examine and figure out. So definitely that will happen only if the patient develop one of the complications of the monkeypox. So what are the complications of the monkeypox? Of course, there are certain non-specific symptoms which you already told, and there can be complications. That means the vesicles can get infected with bacteria. So bacterial superinfection. Sometimes the vesicle can happen in the eye. So the corneal infection, and then there could be pneumonia, sepsis, cellulitis, respiratory distress, and even the involvement of the brain, that is encephalitis. So encephalitis is the involvement of the brain due to the monkeypox virus, and that is what we are suspecting in the case of monkeypox death which happened in Kerala. It's very rare, but it can happen. Historically, if you're checking the literature, there are cases of encephalitis. For example, in a literature, what I have in a case series which I have read, 3% of the individuals had neuropsychiatric manifestations, and at least 2 had encephalitis. So definitely encephalitis is a possibility, though rare. And again, the reason for the monkeypox in this particular individual, we are thinking more in terms of encephalitis. But whenever a patient present with a rare manifestation of a rare disease, you have to think of other conditions, like whether the common diseases which would have caused encephalitis, like herpes or other encephalitis causing viruses in Kerala, like Japanese encephalitis or West Nile virus, whether they would have contributed to the mortality. So that also we need to remember. And coming to the diagnostics. So how will you diagnose a monkeypox? Of course, clinically you can suspect, but then you have to confirm. And ICMR NIV Pune is where currently we are sending the samples. But definitely other centers are also getting opened up, including our Alappuzha NIV center is opened up now. And what are they doing? How are they diagnosing? So now we know RT-PCR is a household name. RT-PCR is a household name because of COVID. Everybody gets an RT-PCR. At least during some portion of the COVID pandemic, every shops or every airports, they mandated the RT-PCR report before allowing you to get into a flight or things like that. So everybody knows PCR. So first, as I told in the initial slide, they are coming under the family of orthopox virus. So they will check for the PCR to see if the monkeypox virus is belonging to this particular family. And if it is positive, the PCR is positive for orthopox, then they will go for specific test for monkeypox, and that's how they are diagnosing. And if you have a patient suspected of monkeypox, then what all samples you need to send to the NIV Pune or whichever virology lab you are planning to send the samples to. So depending upon the phase, you can decide whether the patient is presenting to you at rash phase or recovery phase. If the patient is presenting to you in the rash phase, that means the patient has a lot of rash in the body. Then from the lesion fluid, you can aspirate the fluid from the lesion and send for PCR testing. The lesion scab can be taken. You scrap the scab using a blade and send. Lesion roof can be sent. Blood can be sent. Serum can be sent. Nasopharyngeal swab, we all know how we got so many COVID testing during the period, and even the urine can be sent. And in the first case of Kerala, I actually heard a talk by Dr. Aravind, who managed the first patient of monkeypox in Kerala. So he was telling that he sent all these samples to NIV Pune, and all of the sample detected to have monkeypox PCR. So thing is that, but in that particular case, that was the case, but in not every patient, that may not be the case. So all these specimens you need to send. So at least if we are missing in some specimen, in few specimen, we will be able to pick up the monkeypox virus. In recovery phase, of course, you need not, you don't have the rashes to send fluid or any kind of specimen from the rashes. So you will have to send samples of blood and urine and see if PCR is still positive or not. And how to sample pack and transport. Of course, once you take the sample, keep it at a 4 degrees Celsius, appropriately label the sample tubes, seal with paraffin, centrifuge the serum tube before shipment, and tubes to be wrapped with absorbent tissue paper so that in case of some spillage, it will not spoil the whole thing. And then place it in a Ziploc bag. Sample should be transported in dry ice. Basically, triple packing you have to do. Okay, in the first, you can see the initial paraffin placement they are doing, and then around the tube and in the centrifuge tube, around the tube, they are filling it with cotton so that spillage can be prevented. Then then they are keeping it in the Ziploc bag, again into the container, and then again into the thermocol box. So basically, triple covering is what you need to do in case of shipment of monkeypox virus. And what are the core surveillance strategy which we are adopting? One is hospital-based surveillance, especially in dermatology clinic, STD clinic, medicine, pediatrics, even surgery, because the patient can have proctitis and genital ulcers, oral ulcers, anal ulcers. So hospital-based surveillance is happening. And then there is targeted surveillance. Targeted surveillance is happening via the measles surveillance system, which is already existing, and also via the targeted intervention sites identified by NACO for MSM and FSW populations. Contact tracing. Why you want to contact trace? Because we know it is a disease and it is spreading. So any at-risk individuals you have to trace, because just like in COVID, trace, isolate, so that the chain of cycle, that is break the chain. So contact, identify, isolate, and trace, identify, and isolate. So that is again the same mechanism which we are following here. And in case if you have done contact tracing, and if you want to know how long the patient need to be isolated, or patient need to be monitored, then 21 days the period. During 21 days, if there were no symptoms, then the chance of them getting monkeypox is kind of negligible. So 21 days is the isolation period. And what are the infection control practices? In case if you are in a hospital, And if you have a monkeypox patient, what are the infection control practices? Do you need to do any special precautions? Actually, there is no real need to do any kind of special precautions. Standard precautions will do, and contact precaution, because basically it is a contact disease. And in case of COVID, we need to keep an N95 mask because it was an airborne disease. This being a droplet precaution, this being a droplet transmission, even a triple layer mask will do. So these are the infection prevention and control practices which you need to do. And what about isolating the patient? Isolation of the patient in an isolation room of the hospital. At home, if the individual is at home, then a separate room with separate ventilation. And patient also has to wear a triple layer mask. Skin lesions should be covered to the best extent possible with long sleeves, long pants, so that we can minimize the contact with others. Isolation to be continued until all lesions have resolved and scabs have completely fallen off. So that's.
I didn't get that. Could you try again?
So that's that. And principles of patient management. I think my series. Principles of patient management. One, patient isolation, which we already told. Then protection of compromised skin and mucous membrane, rehydration therapy and nutritional support, symptom alleviation, and monitoring and treatment of complication. So these are the various heads in which you will treat an individual who has monkeypox. So supportive management, as we all know, at least the cornerstone of treatment is mainly the supportive care. For example, if there is a skin rash, then cover with light dressing, do not touch or scratch. In case of secondary infection, then treat with antibiotics. Otherwise, no need to use antibiotics. And emollients can be applied so that it will not get burst, or it will be soothed. So basically, and simple antiseptics can be applied. So all these things can use. And if there is a genital ulcer, sitz bath can be given. Oral ulcers, then warm saline gargles or topical anti-inflammatory creams. And if there is a conjunctivitis, some eye drops. So basically, again, the core idea is that see for the symptom, look for the symptom, and whatever the symptom the patient has, treat that particular symptom so that the patient will feel relaxed and the immunity will take care of the infection in the subsequent period. And coming to the vaccination. So when properly administered before an exposure, vaccines are effective in protecting people against monkeypox. There are two vaccines available. One is ACAM 2000 and JNews. So remember, these two vaccines are not really against monkeypox, but these vaccines are actually against smallpox. But since we know that both of them are from orthopox virus family, the monkeypox, the vaccine which was originally targeted smallpox, will have 85% protection against monkeypox, which is a pretty good number. So that is why even in US or even in Europe, they have accepted the smallpox vaccine as a preventive measure to at-risk individuals. And this ACAM 2000 is kind of live virus with multiplication potential. So not the preferred vaccine, but JNews is live virus, but without replication potential. And that is the vaccine which is mainly in use. The other only if we cannot use the if we don't have enough supply of JNews, then only the other live replicating virus vaccine, that is ACAM 2000, need to be used. So what about post-exposure prophylaxis? How and when to give post-exposure prophylaxis, so that if you come in contact with a patient who has monkeypox, and then you don't want to get the infection, you want to prevent the infection, but maybe you have shared the same linen, or maybe you have talked to that particular individual for a prolonged period, maybe you are a healthcare worker who had to take care of the patient. Then in such scenario, you are definitely a contact. So now what you can do is a post-exposure prophylaxis. So just like in varicella zoster or chickenpox, within the first 4 days, take the vaccine. This will prevent or abate the development of infection. If given between 4 and 14 days, you might get the disease, but even if you are getting the disease severity will be less. So that's about the post-exposure prophylaxis. And what about pre-exposure prophylaxis? That means you are not yet exposed, but you don't want to get the infection. So for a normal individual, you need not go for a pre-exposure prophylaxis. But if you are a high-risk individual, like those who are handling the virus, like lab workers, or if you are taking care of the if you are taking care of the patient who already contracted monkeypox, then you definitely have to, not definitely, it would be better if you could take pre-exposure prophylaxis. And CDC is recommending those high-risk individuals to take pre-exposure prophylaxis because of their profession. And other treatment considerations. People with severe disease, people who may be at high risk of severe disease, like immunocompromised patients or pediatric patients, or people who have other skin diseases like atopic dermatitis or exfoliative dermatitis, pregnant women. So these individuals, if they are getting monkeypox, there's a high likelihood that they might get a severe disease. So in such scenario, we might have to treat them a little bit extensively. The supportive therapy may not be adequate. So do we have any other antiviral with us? So again, just like in the vaccine, there is an antiviral called tecovirimat. This was again found to be useful against smallpox and approved for the treatment of smallpox in 2018. So this is the antiviral which we have, and FDA approved tecovirimat for using in monkeypox in the above said situations where the host is kind of immunocompromised and vulnerable, and the treatment duration is 14 days. Safety is also established in human trials. Of course, there are other antivirals like cidofovir, which we classically used for CMV, retinitis in AIDS, and it's proposed that cidofovir as well as its prodrug brincidofovir might be effective in case of monkeypox. But till now, tecovirimat is the one which is approved by US FDA. And that's about the treatment. In case if you have any doubt, I have skipped through various sections because I was not 100% sure about the audience. I thought sometimes it might be little supracortical, so I don't want to sound too technical. So I thought, in case if someone have any doubt, I thought I will finish it in 40 minutes, but I think it's almost 44 minutes, but that's fine. If anyone has any doubt or any questions, now I think I can take it.
Yeah, thank you. We have a couple of questions. I'm just going to read out. So the first question is, good evening, doctor. Please give guidelines for prevention and also to improve immunity.
Regarding prevention, first thing I have told, you need to know how the disease is getting transmitted, which I already told. So basically the disease primarily is happening in men who have sex with men or the homosexual individuals. So if for them the prevention, one thing I can definitely tell is that to reduce the number of partners. And if you don't know someone, then definitely you should not go into those kind of relationship, at least during the current times. And if you have symptoms or epidemiological link of a monkeypox-like illness, definitely consult a doctor and watch for the symptoms. If there are symptoms, then need to be in isolation for a period of 21 days. I think that addressed the first part of the question. What was the second part of the question?
It's about immunity, doctor.
Immunity. So immunity, as we know, there are two types of immunity. One is passive immunity. Second is the active immunity. So active immunity, I already told, that is via vaccination. So two types of vaccination is there, but Jynneos, or I think in Europe, its name is something like ICAM. So that vaccine you can use to boost the immunity, but in India, it's not yet available. And regarding passive immunity, there is intravenous immunoglobulin against variola, which can be used if a patient is at very high risk of developing monkeypox and who is going to develop severe monkeypox due to the underlying immunocompromised status the patient has. Other than that, if you are taking vitamins or minerals, that is not going to help you for sure.
Thank you, doctor. The next question is, will chickenpox vaccine give cross protection?
The answer is no. The smallpox vaccine is the vaccine which we are giving for monkeypox. That is because both of them are from the same family, known as the orthopox virus family. As I told in the beginning, the chickenpox belongs to a separate family called herpes viridae family. So there will not be any cross protection.
Okay, doctor. Thank you. The next question is, does COVID vaccination, both Covaxin and Covishield, have any interaction with the monkeypox vaccine?
As far as I know, no. And, like I will not able to give a definite answer for that because I don't think there will be any studies done on that. But one thing we can tell for sure is that nowadays, even if anyone has to take other vaccine along with the COVID vaccine, we are not asking them to delay the vaccination or anything. Initially, we used to tell them to keep a 4-week delay. Later, it came down to 2-week delay, and now 1-week delay. And now, even on the same day, if the two people, if an individual is taking one or more than one vaccine, we don't really bother. And there are enough studies to suggest that that will not prevent an individual from mounting the immunity. Since that is the case, as a general statement, I can tell that in case if somebody wants to take both the vaccine, they are welcome to do that. Only thing is that one is live vaccine, other is skilled vaccine, but that should not be an issue.
Thank you, doctor. The next question is, okay, like vaccines against COVID, can everybody take irrespective of age, diabetics, CVD? Maybe I think the vaccine that you have told right now for the, monkeypox, I think that is related to that.
No, I think the question is not related to monkeypox, but it is a general question related to COVID vaccination. So whether there is any particular contraindication for COVID vaccine. So again, that depends upon the type of vaccine. Since we are from India, the vaccine which is available with us is basically the Covaxin, Covishield, then the Sputnik vaccine, as well as Corbevax is there, but that is mainly in kids. Novavax is also there. So and the majority of them are taking Covishield vaccine. The answer is, unless you have an allergy to one of the constituents of the vaccine, there is no absolute contraindication for COVID vaccination. Even when we started, we were very reluctant to give the COVID vaccination to people who had past history of anaphylaxis or past history of autoimmune or demyelinating disorders, inflammatory disorders, inflammatory bowel disorders. But then after a point of time, we started giving to everybody. And of course, there were some history of post-vaccination thrombotic events, post-vaccination thrombotic events and post-vaccination vasculitis, but there is no way to predict who is going to get it. So as far as I am concerned, I cannot tell a definite contraindication for COVID vaccination. Anyone can take. And as you told, if there are more, if there are more risk factors like diabetes, hypertension, obesity, then it is better to take, because if you are getting a disease, then you are highly likely to get a severe disease as the comorbidities increases. So the vaccination will definitely protect you against the severe disease.
Thank you, doctor. The next question is, once infected, is there a chance to get infection again?
Monkeypox?
They had mentioned about COVID or monkeypox. Let's take the current scenario of monkeypox only then.
Okay, so anyway, it's a monkeypox seminar. So let's assume that the question is related to monkeypox. I cannot give a 100% conclusive answer, but most probably no. Not only monkeypox, chickenpox, smallpox. From historically, we know that once these kind of viral infections come, it will generate such a strong immune memory, so that it will protect lifelong an individual against those kind of infections. So the answer is no.
Okay, doctor. The next question is, can elective or emergency surgeries be proceeded when the victim has sustained monkeypox?
Okay, so the question is elective surgery. First, we will discuss the elective surgery. Why somebody would want to do elective surgery when an individual has monkeypox? Because it is elective. The term elective means it's not an emergency. So definitely postpone it. Not only monkeypox, even if you have a small viral infection, if it is an elective surgery, always postpone. So that is the dictum. So there is nothing to discuss in that particular regard. But as far as emergency surgeries are concerned, so now the question is emergency. How emergency the surgery is? If it is real emergency, then it is always the risk versus benefit. So when a patient is already sick, especially sick with a disease like monkeypox, by default, if you are operating on the individual, the perioperative period is likely to be very much complicated. In such a scenario, if you are operating on an individual who already has monkeypox, and might be will consider it as a severe monkeypox infection, then the perioperative risk of complication is high. So again, you have to revisit the emergency and see if you are not doing the surgery. For example, if the appendix is going to perforate, then if you are not going to do the surgery, it is highly likely that as appendix is going to perforate, and then there is going to be peritonitis, and which can even lead to death. So always take into consideration the risk versus benefit. And in that scenario, you can revisit the whole thing. And if the particular surgeon as well as the physician or the ID physician, whoever is taking care of the monkeypox patient, they can take a combined decision whether the risk is more than benefit. So it is an individual decision, and the surgeon should tell how emergency the surgery is. If there is absolutely no chance the patient to survive without surgery, then yes, you should proceed with the surgery.
Thank you, doctor. And the next question is, won't smallpox vaccination give protection? Those born before 1976 or 77 will be protected, isn't it?
Yeah, the answer is yes. And things that, again, when we tell about protection, you cannot anticipate the protection to be in absolute. That means it's not that once you have taken smallpox, you will not get the vaccine. For example, yesterday I was reading a case series in which one family got infected, 2 adults and 2 children, out of which the severest infection was for the kids, and the mildest infection was for that elder person in that family who already received smallpox. So thing is that once you have received smallpox, the percentage probability of you getting a monkeypox infection is rare, or it's less. And even if you are getting, it is almost highly likely that you are getting the mildest form of the illness.
Okay, doctor. Thank you. The next question is, do we have to be worried for monkeypox in India like COVID?
So I have shown a chart where the rate of infection every month, it is increasing by incidence of infections increasing in thousands. But if anyone has followed the spread of COVID, then we know that's not how a real pandemic multiplies. It was multiplying. It was a geometric progression: 2, 4, 8, 12. In China, in Wuhan, the first chart, you can see it was always like 2, 4, 8, 40, 8, 16, 32, 64, 100. So it was geometrically progressing. And compared to that, monkeypox is kind of very self-limited disease. If you are doing the caution during this particular outbreak period, and if you are if you know how the transmission is, and if you are restraining yourself from those kind of activities, then definitely the chance of you getting monkeypox is kind of very, very rare.
Thank you, doctor. The next, can we take 2 more questions, doctor?
Yeah. I think now what is the time now? 7:56. That's okay.
Yeah. So the next question is, could you brief more about antivirals to treat patients with monkeypox?
Thing is that I already told, no, the only drug which is currently approved antiviral is tecovirimat. That is approved by the US FDA, and it's not, they are not using it for every individual, but at-risk individual, or at-risk individual means individuals who are likely to get severe infections like immunocompromised status, or the atopic dermatitis, eczema, pregnant women. So these kind of individuals, once they contract the disease, by default there is a possibility of them getting a severe disease. So in those individuals, whatever remedies we need to mitigate the severity of the infection, we will have to do. And hence, in those kind of individuals, we can give the antiviral tecovirimat. But in India, it's still not available. So I think it's more of a theoretical discussion, but still it might come to India soon.
Thank you, doctor. The next question is, who are at more risk of developing the complication of monkeypox? Does the government, doctor, could you check the Q&A now?
Q&A, yeah, 1 second.
Yes.
Who are at more risk of developing the complications of monkeypox? Does tecovirimat prevent these complications if you within the time frame? So within the time frame, that is, once you are exposed, the drug which we use for prevention is not tecovirimat. Let's be very clear. That is the vaccine. Use vaccine, induce your immunity, prevent. This is an antiviral. So in first place, there has to be virus, which means you have to contract the disease. You have to see the vesicle or lesion, enanthem, exanthem, macule, papule, something has to be there, which means the virus is there. Once you detect the virus, you give tecovirimat. Before there is viral manifestation, or there is no point in giving tecovirimat for prevention. For prevention, you induce the immunity by giving a weak virus. That is the vaccine.
Thank you, doctor. The next question is, what is blood in SSGT?
What is blood in SSGT? I didn't really get that question.
Even I didn't. So let's move into next question. I would request, Ms. Parvati, maybe if you can brief more about the question so that doctor can answer. And moving to the next question, how long does it take to get rid of monkeypox?
So as we stand today, 21 days is the period where a patient can go through all the stages, cutaneous stages of monkeypox lesions, which I have described, and the scab will form, and finally the scab will fall off. So it can be as early as 14 days, but it can be as late as 21 days. So let's decide 21 days.
Thank you, doctor. The next question is, people born in 1950 to 1960, vaccination was given. Isn't that against smallpox?
Yeah.
Okay, fine. I think, doctor, we have taken all the questions. So 1 minute. So the next question is, can diabetes CVD patients above 60 years take vaccine against monkeypox? Where is it available?
The current strategy which is being practiced, or which the major governmental bodies are recommending, is not to take monkeypox vaccine for every individuals, but only to give monkeypox vaccine, because the vaccine is not that freely available. It is in short supply. So only to high risk individuals. That means, the occupation. If they are in that kind of occupation, or if their characters that kind of character, or if they are belonging to that kind of community, LGBTQ community, then definitely monkeypox can be given. But other than that, right now, even for that, it might take few more days or few more weeks. But right now, if one had a definite exposure with a patient who has monkeypox, then that exposure they are categorizing into high risk or intermediate risk exposure. High risk means direct contact. Intermediate risk, for all practical purpose, let's say the contact with a linen, or maybe they have given some assistance to that person who has monkeypox. So in those kind of situation, it is not a high risk contact. It is not a sexual contact, or it is not a close contact for a prolonged period. So if a patient is having a close contact for a prolonged period, then definitely that individual needs to take. If it is an intermediate risk, then not really need to take. And if it is low risk, that means, just used the linen here and there, touched the linen, they just needs to get observed. Another way, or another strategy which the communities, the societies are planning, is ring vaccination. That means they will, for example, a householder is developing smallpox, then anyone who came into that house, they are kind of at risk individuals only, maybe low risk or high risk, but at risk individuals. So vaccinate all these individuals so that they will not contract the disease and they will not spread the disease also. So it is like a preventive strategy. So these are the strategies which commonly use for vaccination in case of monkeypox.
Thank you, doctor. The next question is, what are the current treatments available for monkeypox?
I think we already discussed. One is preventive aspect. Second is, of course, antiviral tecovirimat, and then basically supportive care. Most of the viral infection, for the first case of monkeypox in Kerala, he had severe odynophagia. He was unable to take anything. So during that kind of situation, you might have to feed him via a rice tube, or maybe you might have to give some IV fluids, some analgesics to support him. And once you support him through that period, then he will recover his own. And just see if there is some super infections is developing. Treat the super infection. Watch for any corneal ulcers. Treat it so that they will not get corneal scarring. So basically, observe the patient, and whatever symptom the patient has or sign the patient has, treat it. So that's how the strategy goes. I think now we have crossed 8 p.m. I think we should wind up.
Yes, doctor. I think we have taken up all the questions as well. So let's wind up the session today. So on behalf of MedPiper Technologies and ISA, we would like to thank Dr. Deepu for spending your evening with us, to talk about monkeypox and related, treatments, vaccines, and everything, what needs to be taken care of and everything. Thank you so much, doctor, for joining us today. Yeah, and thank you all the participants who joined and who have asked questions continuously, and we can see you for the next session.
Yeah, thank you for your enthusiasm.